and epidemic control within Periscope, because many of us working with the Firoz Lalji Institute or our partner institutions like the IDS and Sussex have worked predominantly in Africa and elsewhere, notably on diseases like Ebola. And thinking about that context, thinking about epidemics in that context creates a different set of concerns. And I was very struck listening to Laura just now, talking about the problems for epidemics in the context, the problem of epidemics in the context of democracies. Things spin very differently in other places, where trajectories of governance are moving away from democratic spaces to more autocratic. And epidemics spin in different ways in those contexts. And so we're going to have some conversations about those issues here today. Did we actually have an order? Melissa, were you going first? Okay, so rather confusingly, we have two Melissas. They're in the middle there. One's got blonde hair, one's got brown hair, so you can tell the difference between. Okay, so we're going to have first Melissa Parker, who's going to talk a bit about some of the work we've been doing in Uganda. What have I done? I've pushed the button. Oh no, the wrong button. Thanks, you at the end. That's sending us all home. What have I done? Okay, fine. I'm going to sit in your feet. I'm going to go there. You can keep walking around. You could do, yeah. You could speak from here, not then. When you're there.
Okay, great. So I'm going to talk about some collaborative work that has been done by these three marvelous individuals, Melissa, Tim, Hayley, and I, and also some wonderful Ugandan colleagues who are named there on this slide. Without whom this work would not have been possible. So I guess just to cut to the chase, there's a very long history, some of you will be aware, of armed forces being mobilized to contain outbreaks of infectious disease. In fact, several international health organizations emerged out of wars, including the World Health Organization, whose constitution, to remind you, states the health of all people is fundamental to the attainment of peace and security. And that was in 1948. Since then, there have been very important changes in militarized trajectories of healthcare, including the involvement of the UN Security Council. One particularly important change occurred during the West Africa Ebola outbreak in 2014-2016, when the UN Security Council passed Resolution 2177, which asserted that the unprecedented extent of the Ebola outbreak in Africa constitutes a threat to international peace and security. Now, this resolution was incredibly important and paved the way for a highly militarized approach to treatment and containment in West Africa. But it also had very important and profound impacts for the way in which governments responded to the COVID-19 pandemic. So just as an illustration, we're going to focus on Uganda, which had a highly militarized response to COVID. And our research focused particularly on these questions. What are the day-to-day impacts of sustained military engagement for ordinary citizens? Did people actually feel less secure as a result of the militarized response to COVID-19? And what have been the broader socio-political ramifications of taking such a militarized approach? Now, to try and address these questions, we did some long-term ethnographic research, focusing in particular on Kapeti and Kwach districts. And that work began actually prior to the outbreak of the pandemic, but continued right through it. The Ugandan colleagues in sort of weekly conversation with us over Zoom and WhatsApp and everything else as we kind of tried to unpack and explore what was actually happening on the ground. it's maybe very important to actually highlight the political context in which COVID-19 unfolded in Uganda. Some of you will know that President Museveni came to power in 1986. And in 2018, at the grand age of 73, he passed a law which removed the 75-year age cap for presidential candidates, thereby ensuring that he could run for re-election in the 2021 election, which was right in the middle of the pandemic. In anticipation of the election, it was already being reported pre-pandemic by journalists and human rights organizations that he was pursuing a policy of threatening and beating up opposition leaders, including Bobi Wine, leader of the People Power Movement. So COVID-19 unfolded in a very fraught political context. But from the outside, it looked as if Uganda was quick off the mark to respond to the pandemic. This tweet by President Museveni, for example, conveyed an acute awareness of public health security narratives promoting the need to be prepared. And action followed very swiftly. Following an address on March 18th to the nation, he closed schools, suspended markets and religious gatherings, and political rallies were forbidden. And all this happened before the first COVID-19 case was reported in Uganda. Very, very different to the UK situation. Crucially, power was taken away from the Public Health Emergency Operations Centre, and all decisions had to be authorised by the Office of the Prime Minister, with a military figure heading those operations. And this overt militarisation had very brutal dimensions. I've actually downloaded this picture from the web, which was taken in Kampala, but it resonates with accounts elicited at all of our study camps. For example, a young man from Kaseki district, reflecting on the violence being meted out by soldiers, said, "These soldiers you see have no mercy. They beat you like you are a snake. No one can run there to stop them being beaten, to stop them beating people unless you resemble them or you are their boss." Very powerful statement. At another site in Patch district, which lies more than 400 miles further north from the shores of Lake Albert, people were not only beaten, but live shots were fired into a fish market. Those shots were fired literally within hours of this presidential announcement, so before most people had any idea that there was a lockdown to be announced. These kinds of quotes came thick and fast from the field during this time. So, for example, this is a pastor speaking. He said, "That fateful day, the security forces stopped me, and without saying a thing, they descended on me with sticks. They beat me until I lost consciousness." And I think it was 5 minutes later. Female fish seller described how she encountered, quote, "the wrath of Museveni's men," when an armed man beat her with sticks until she lost control and fell down. And a motorcycle rider described how he was caned for defying a presidential directive. He'd actually taken a very sick friend to a hospital which was 45 minutes away, and he was on his way back. He went on to say, "I tried pleading with the officers, but they kept a deaf ear. They took me to a police station and vowed not to return my motorbike until an unreceipted fine of 150,000 Ugandan shillings was paid." Now, it's very important to remember that these very heavy-handed responses happened at a time in which there were no recorded cases of COVID-19 in these two districts. And there was a widespread perception at all field sites that COVID-19 was not as serious as afflictions such as malaria and typhoid. So these kinds of comments were widely shared. Things like, "It's a natural sickness just like malaria. It's a common flu that can't kill. It can easily be cured by eating and chewing bitter fruits. COVID doesn't kill us Africans. Few people, not that many, thought it didn't even exist. And others said, COVID is easy to treat. People who consume fruits like lemon can't be infected with coronavirus easily. It's also important to highlight the point that there was a very strong military presence at both field sites, not only through the first lockdown and the second lockdown, which occurred the following year, but that there was an enduring presence between those two lockdowns in which there were sort of, in theory at least, lighter restrictions. So perhaps not surprisingly, given the importance of having to access markets and secure livelihoods, that created a situation in which people felt they had absolutely no choice but to devise their own strategies to resist and dodge military patrols along the border. So there was a whole number of ways in which people did this, and it varied a little bit between our field sites, but one of which was to pay payments to military officers to, if you like, turn a blind eye at the crucial moment. Others was just simply to pay them a certain portion of the profits so that traffic, trade and such would pass. But to quote a Cassetti's trader, the UPDF is busy wanting to arrest blood smugglers like me, but we understand each other, and both we and they are working collaboratively. He went on to describe how mobile money was sometimes sent to their account in advance of their arrival at the border, just to be sure that they would look away at the crucial moment. Others focus their energies on devising strategies to outmaneuver soldiers and militia groups operating nearby. In Cassetti, for example, a woman told us how her husband would ring her from the DRC to provide updates of the whereabouts of the militia group. And when the path was clear, she and her friends would cross the river from Uganda into DRC. This was usually at night time, and somehow or other they managed to return to their village in Uganda with enough crops to order. Such acts of public mutuality reveal the way in which people come together and assist each other in times of adversity. But they also reveal the counterproductive consequences of relying on the military to impose containment strategies. In fact, the enduring everyday impacts of militarizing the response has ended up leaving people with a heightened sense of insecurity. This is partly because the economic impacts of lockdown have ended up being more disruptive than the infection of COVID-19. So the following quote from a farmer living in the Uganda DRC border elucidates the way in which security is linked to maintaining livelihoods. He said, "In the absence of money, there is no way I can feel secure. Being free from diseases means being safe. Our health problem these days is malaria and typhus. The medical prescriptions given in the health centre require us to have money in our pockets to be able to buy the drugs prescribed. All this is the safety I'm talking about." So our fieldwork raises another important question. Did the militarised response have any discernible impact on the epidemic? Did it interrupt transmission and flatten the curve? This is actually a very difficult question to answer, not least because testing was very limited and officially reported data was initially only based on the PCR results. Nevertheless, have a look at this. It's based on work I've been doing with Nick Lang and Sophie Myland, both of whom were actually in Uganda throughout the pandemic. What we actually did, and this is around the second wave of COVID in Uganda, is we mapped out officially reported cases by the Ugandan government on a kind of day-by-day basis. And then we looked at where the restrictions were actually imposed on those specific days and how that may or may not relate to changing patterns of infection. So for the second wave, initial restrictions were introduced only on June 7th, over 2 weeks after the start of the outbreak. Now, those initial restrictions were actually very light. People moved freely on motorcycles and public transport within districts, and most markets and shops were open. So for some observers, at least, They might not even have been aware that there were restrictions in place. So the peak of the outbreak had actually already passed before a more extreme lockdown was instituted on the 18th of June, with all public transport banned and retail shops closed. All of this suggests and supports the idea that the dominant narrative that the public health and social measures introduced by Museveni were successful. Clearly, they need to be reconsidered, and there may be, and at least to think about what those alternative explanations might look like. So let me just end with a final comment. It is, I hope, evident to all of you that, at least in Uganda, global discourses about the importance of establishing public health security were mobilized actually to hollow out democratic processes and strengthen authoritarian rule. So far, the majority of international donors and commentators have chosen not to condone what in other circumstances would be recognized as human rights abuses. On the contrary, data analysed by a Lancet commission suggested that Uganda had been more successful, quote unquote, than any other African country in containing COVID-19, ranking it 10 out of 191 countries. And in recognition of this so-called achievement, the BMJ and the NHS Health Education Programme awarded President Museveni a medal for his extraordinary leadership in pandemic management. So I think I'm going to end there and pass over to Haley.
Sorry. We'll get back to the yeah.
Sure.
No, so Melissa Leach and I were involved in the same project that Melissa Parker was speaking to, which is called, which is on pandemic preparedness, a Welcome Collaborative Award. And we're going to really try and sort of look more broadly at the implications of these findings that Melissa Parker has presented. And it's the sort of obvious conclusion one can take, if we're going to broaden out, of course, is this point that we can see quite clearly that the national political context and histories obviously shaped responses in different places. And there's a lot of talk at the moment about global ideals around pandemic governance, pandemic preparedness, but in these kinds of examples, we really see how these come up against these national and political realities, and but also intersected with commercial interests, corruption, and sort of jockeying around resources that flowed in during COVID-19. And in this context, the discourse that securitized public health then enabled this politicization of the response. And what we've also seen in this work is really the difficulty for global committees within the WHO and so forth to actually engage directly with this politicization and these human rights abuses, as Melissa alluded to when she talked about the award, for example, given to President Museveni. And at the moment in the negotiations, what we're seeing is a sort of gesturing at ideas about trust and equity, but not much engagement with these sort of very difficult realities, this kind of undermining of democratic norms that happened in Uganda. Of course, there was this overt politicization with the election imminent, and that was seen also in our research with the vaccine rollout. This really violent, repressive response continued, particularly directed against marginalized populations in the north of the country. In the other place where we've been doing fieldwork in Sierra Leone, we saw this playing out in a slightly different way, where there'd been a long civil war, where the military played a role to bring peace, and thus was more trusted to some extent as a professional force. So they helped with the logistics of COVID response, but in some localities, people also experienced harassment, for example, from border guards entering villages demanding money and food or sex. And another comparative African context that I know is in South Africa, where there was also a noted harshness of response in 2020 and the first outbreak, with the police being involved in quite violent, punitive acts and sort of linking back to a repressive past and national political rivalries. But interestingly, in that setting, very quickly by June 2020, there was a shift to a discourse of sort of individual responsibility in containing COVID, a real shift to concern about the economy. And what's notable from the Ugandan example, of course, is that the repression was sort of unrelenting and continued. So this all really requires a political analysis. And Melissa's presentation really emphasized that there were these very different understandings people had about safety. People were facing these multiple insecurities and threats to their life. That really then the pandemic response was actually undermined. It made for the militarization made for a less effective response, as that final slide showed there. So there were these sort of unintended consequences of that, where people had to sort of undermine public health efforts to maintain their lives and livelihoods. So the point being that the understandings of security went far beyond the sort of military security, or people's understandings went beyond security or safety as disease control, but were much more related to what one might call a sort of human security. And in our work, we've really tried to look at precarity as a kind of counterpoint to that security discourse, and to really ask questions about what that might mean then for pandemic preparedness and how one might achieve a more socially just and equitable and effective pandemic preparedness and response. And what's interesting is that in the sort of current talks around reframing or trying to rethink pandemic governance, there's still very much this framing around security. So pandemic preparedness is fundamentally still framed around security. Mike Ryan from the WHO Health Emergencies Program recently spoke about needing to build global health security from the bottom up. And really we feel a sort of dearth of critical reflection thus on security and how one might really try and reframe the securitized response. I'm going to really give it just a brief introduction to our project, which was very much focused on meanings and practices of preparedness, but from what we talked about as preparedness from below. And in this regard, we were really trying to shift the perspective to sort of places in the world where people have had to deal in an ongoing way with pandemics. So we're trying to do this as a contribution to this kind of task of shifting power in pandemics. So we're not trying to speak from the margins to the center or from the bottom up in a sort of hierarchical schema, but really trying to encourage greater appreciation of the everyday experiences that are really central to pandemic preparedness and response, and trying to think a little bit about what the experience might be in villages in Uganda and Sierra Leone, and how one can facilitate greater connectedness and some equitable dialogue between people in these located settings and the national and international agencies and organizations that are talking about how to prepare and respond. And we were really sort of trying to look at these resource poor places in African settings that are often the focus of these pandemic imaginaries, and that conjure up these assumptions around hotspots and sort of victims, deficit ignorance, and becomes the target then of pandemic interventions from above, if you will. And we were trying to really explore critique and to sort of challenge some of those assumptions and power relations, and look more directly at everyday experiences of disease and understandings in these sites in Sierra Leone and Uganda. And this work really came out of responses to Ebola, so how people actually mobilized directly to try and protect themselves from the disease, to bury their dead according to more cultural logics around ethics of care, and to try and protect themselves from the disease. But what we saw with COVID, as you heard from Melissa, was that in these village sites, there wasn't actually visible high mortality from the disease. So in fact, what emerged from the fieldwork is that people were really dealing with a whole mass of other challenges, including everyday seasonal challenges, challenges in livelihoods, food, trade, a host of other health conditions, these insecurities that Melissa spoke of. And these could really be considered more as on a different temporality, as ongoing slow emergencies that were sort of affecting people's lives. And in the midst of this, the sort of epidemic shock was really unlikely to be singled out in a dramatic way, and particularly when the overall mortality wasn't high and when people had a high burden of endemic disease. And this very much came out. We talked about how people navigating these intersecting precarities and the kinds of experiential knowledge that they drew on to do so, and referencing wider bodily, social and political understandings, and trying to sort of unpack what kind of local knowledge was vital to this kind of preparedness. And what also emerged really is that there were also diverse forms of collective organization that emerged. So people were trying to deal with the effects of lockdown to a large extent, and drawing on women's networks and groups that had existed before the pandemic, groups of market traders in Sierra Leone to try and sort of work to reopen markets, drawing on these relationships that were really part of the pre-existing fabric of life and had been mobilized in the past to deal with these everyday uncertainties. So we were looking at these forms of mutual support that developed, but also sort of collaboration to get around some of the repressive responses, for example, in Kasese district, where that Melissa spoke about, where people were trying to make payments to get access to their gardens across the borders in DRC. So really, all of this, I think, raises big questions then for how one brings this kind of perspective and creates a more equitable dialogue with some of these other framings of preparedness that we might get in global institutions, and particularly ideas around so-called community engagement. So really, trying to think about preparedness as a sort of building up of everyday small acts that are part of the social fabric, and to try and get away from a more of an idea of these community capacities as some are exceptional, they have to be identified and strengthened, but rather seeing them as present, and that the everyday and taken for granted can in fact become exceptional. So I'm going to pass over to Melissa Lalji now to think a bit about what that means practically for speaking to current debates about pandemic preparedness.
Thank you, Hayley, and thank you, Melissa. And it's been a great project, actually. So I just want to, sort of building on both the previous presentations, just to ask, what does all of this sort of set of understandings about preparedness from below that have emerged through our projects, and the reframing of security that it suggests mean for future pandemic governance? And I've got 6 points, I think, that are significant. The first is that there needs to be more attention to questions of human rights and how to balance these with disease control. We heard in the introduction, Laura talking about the idea of a pandemic rights declaration. And I think that holds some validity. Certainly discussions about the international health regulations globally need much more critical reflection on the kinds of dangers related to human rights abuses that we've seen in cases like Uganda. And a more explicit human rights lens draws attention to equity beyond debates like the provision of products, vaccine equity, that's currently dominating equity debates. It also means attending seriously to accountability and to trust, which is being discussed at the moment in a parallel panel, but is relevant here too. The WHO is talking more and more about trust, but its own discourse is focused quantitatively on indicators. We think we need a discourse that attends to the politics and relations of trust and the way it plays out not just in formal institutions, but also in informal forms of public authority. So human rights and trust. Secondly, we need a framing that addresses multiple insecurities, which comes closer to that long-standing UN definition of human security. As Hayley's explained, COVID was experienced in our village field sites as a set of disruptions that added to and exacerbated everyday livelihood and health-related precarities. And we ended up advancing the concept of intersecting precarities, which includes the effects of epidemic control measures to capture these. And looking ahead, preparedness really needs to include anticipation of these possible intersecting precarities or insecurities and ways to mitigate them. That might include more proportionate, locally adapted responses. It includes support mechanisms such as the availability of social protection, and it includes attention to better intersectoral responses to deal with these inequitable effects that play out in economy and society, as well as in narrow notions of health. So a third point is that this all requires a longer term framing. Notions of preparedness in global discourses still tend to focus on a single time-bound disease shock, and the standard WHO sequence replicates that in the idea of preparedness, readiness, response, and learning. That really doesn't make much sense, we've found, in relation to locally lived realities, which are much longer term, and people are living overlapping hazards over different timescales. We need, we think, to recast epidemic preparedness and response as these kind of longer term interconnected processes. They may be revealed in immediate shocks, but they're reflective of longer term underlying vulnerabilities and inequities. Manifesting longer term structural violence, it may be about political economy, ongoing relations between citizens and the state, or failures in the availability of things like accessible, affordable healthcare, navigable roads, accessible markets, clean water and sanitation. Paul Farmer, long ago and around Ebola, talked of the basic importance of staff, space and systems in relation to health. Our research has revealed also a range of multi-sectoral system, staff and need issues, from infrastructure and economy to social protection. Put another way, preparedness needs to encompass systems preparedness with respect to both health systems and these wider political economy and infrastructural systems. The fourth point is really about building the capacities among global agencies and national agencies to pick up on and respond to diverse experiences from below so that they can be adapted. For instance, through community engaged surveillance and dialogues that can feed up to national agencies. There is, as Hayley's noted, increased interest globally in what often is being called community capacities or community resilience. And the WHO has a new unit on community readiness and resilience for precisely that. But there's a danger that, that we become overly focused, first of all, on quantitative indicators for measuring them in overly technical ways, ways that don't pick up on the relations and institutions that are actually important to people, and also that they don't take account of limitations. Community resilience can so easily pass the buck over to communities to cope without recognizing the need for authorities who are trusted on to act on behalf of local people, to respond to their concerns and needs, and to make sure that the resources are there for them to enact them. The fifth point is about recasting communication. There's a lot of attention now globally on what's called risk communication and community engagement, RCCE as it's shorthanded, but it focuses on risk, where what we found is that people are dealing with uncertainties. It's often top down, it's oriented to getting people to change their behavior by having the right information. And all this, we think, needs to shift to dialogue, which is much more focused on listening to people's challenges and possibilities, and that incorporates questions about values and care and the relations that shape what's acceptable and possible in a context.
And then finally, all this requires being much more serious about recognizing and adapting to difference and to countering inequities. Global blueprints simply don't do this well, whether they're talking about security or pandemic governance more generally. They tend to be very one-size-fits-all. They don't adapt well to different epidemiologies, the kind of diverse manifestations of COVID that we've seen, to different regional experiences, to diverse socioeconomic and livelihood realities, those amongst different geographies and different groups. I think we badly need to build in much stronger attention to these, at the same time as recognizing that the whole discourse of priorities and regional priorities is itself shaped by historical inequities. This is relevant locally, as we've seen. There are differences between the countries we've looked at and in the places that are shaped by inequities in access to health systems between urban and rural, for instance. It's also relevant globally. And I think with respect to our discussion today, we've been talking about Africa and the African context in Uganda. A lot of Periscope's work has been in Europe. And we've got a very sharp set of global inequities that shape priorities. In as much as COVID caused less mortality in many African countries than in Europe, this is partly an effect of very different demographics and age structures, much younger populations in African contexts that themselves reflect long-term health inequities and life expectancy. To put it really bluntly, many of the people in the age groups that died in Europe don't exist in Uganda, where they simply didn't get to reach that age because of longer-term endemic illnesses and lack of access to healthcare. So in short, I think all of this and what our project has done is to highlight the importance of complex politics, globally, regionally, locally, in shaping what's possible and appropriate in terms of pandemic measures. Preparedness from below, as we've put it, highlights how what is there already in terms of forms of knowledge, agency and authority, trust relations and resources, what shapes what's possible in the moment. But it also recasts preparedness, not as a set of sort of passive anticipatory waiting, perhaps helped by some practice exercises, but an ongoing set of active and highly political processes, and processes that need to be supported in ways that are democratic in the widest possible sense. So that's some thoughts there, and it would be very good to discuss them.
Well, you've got to go up there.
I don't mind, do you want me to go up?
Yeah, go up there. There, you were working on security before we even thought about it.
Yeah, I have been. I've been working on health security for
How long you have?
so I am not part of this project, but actually,
What the very scary.
not part of your project in Uganda and Sierra Leone, but listening to you all, it's so much resonance with everything we've been talking about for 2 decades in health security, right? And what I wanted to kind of mop up, I guess, from everything you've been talking about is something that I've been thinking about in the wake of COVID, which is, have we come to the end of health security as a concept, right? And I think that maybe we have. And I think to kind of get to that point of thinking about have we come to the end of health security, think about where it came from, right? And health security as a concept emerged in the late 90s and early 2000s. It came out of the kind of Clinton administration, HIV/AIDS, recognition of HIV/AIDS as a massive economic impact globally and in the US. And that led to, again, to the UN Security Council resolution on HIV/AIDS being a threat to health and security. And then this was then bolstered by kind of post 9/11 and the kind of uber securitization of everything in our life, right? And so health kind of became part of that as well. And so in kind of early mid 2000s, we saw this huge push towards health securitization, and everything was being securitized. And we had moves at WHO, such as the creation of the updates to the IHR in 2005 to make them kind of stronger in terms of preparedness. And many governments started putting health on, or epidemic, at least epidemic prone disease and potential for disease on security registers, national security strategies, and thinking about it in a very securitized way. And this was done for 2 reasons, right? One was it pushed it up the political agenda, got attention to these issues,
and because it allowed governments and the health sector to draw on military spending, right? Military coffers, which are way bigger than health coffers, right? So it was a, you know, a facilitative way to be able to get more money into the health system. And then we've seen responses to these epidemic events over the last 20 years that have been heavily securitized, right? You were talking about Ebola, about COVID, you can look at it in Zika, in H1N1, in polio to a certain extent. But what we see in all of these responses is in this kind of securitized response is a very similar path dependency in the way that response efforts get launched to respond to these outbreaks, right? And it promotes a certain kind of prioritization, right? It's about how do we stop the pathogen at all costs, right? And it doesn't matter about all of the broader effects of those policies that it introduced, right? And I think this is where we're starting to see the shift now, right, post-COVID. Because I think we're seeing actually that this response isn't good enough. A securitized response that just thinks about killing a pathogen, that doesn't take into consideration the impacts of that prioritization, isn't working for us. Globally, for example, the securitization response and the securitized response to COVID demonstrated that it's a very technical response. It's about how do we get vaccines developed as quickly as possible and into people's arms. And that is the way we are going to get over this, right? Not thinking about the broader social impacts of that. And what we see there is this, you know, we're all very well aware that there was a rush for vaccines, right? Vaccine inequity. Rich countries are getting priority access to vaccines, poor countries aren't. So securitization is failing at that kind of global multilateral level because of the focus on the kind of technical need to, you know, medicalize, militarize, get the vaccine into the arms, you know, using military support to do that as well in many places. And it's leaving the poor behind. This then kind of disrupted this sort of challenge, they're not challenge, the wrong word, inequity between kind of rich countries and poor countries, and then we see at the national level, we see the same dynamics again, right? We see a securitized response, whether it be focused on vaccines, whether it be focused on involvement of the military, whether it be involvement of the security sector. We see prioritizing in the same way, right? It's about how do we stop the pathogen spreading without recognizing what these impacts of these policies are having. So as the group here has been showing, right, the impact of an involvement of the military, right, the brute violence, the impact on human rights. This is something that we have seen several times. We saw it in Brazil during Zika, we saw it in Ebola, we're seeing it here. And we're seeing this kind of lack of consideration by policymakers at the global level and at the national level, I'd argue, about, well, what does that mean, right? What does it mean if your army is your, you know, actor of last resort, is now your actor of first resort? What does that mean for civil military relations going forward? What does that mean for how people are interacting with the military? Can you have, and you know, you're sort of saying you can't have these one-size-fits-all approaches to involvement of the military because military relations look so different in different places. But we also see this kind of and what Laura was talking about in the introduction this morning, the lack of recognition of the social impacts of all these policies that are brought in, right? If you're bringing in strict, NPIs to stop the disease spreading, that has significant societal effects, and we can all think about how all of those have manifested. But what we see is that basically any kind of underlying structural inequalities, structural violences are heightened, right? So a lot of my work during COVID was on gender, and you know what you see is basically women getting left behind, right? Schools are closing, well, who's going to pick up all that unpaid care? It's going to be the women, right? Who's the people who are going to be doing all the voluntary activity in the communities, right? Buying the bread for your neighbour who doesn't want to go out. It's always the women. And actually, I find it a really difficult thing to navigate this challenge of or this kind of push that many people are having, and Laura was talking about this morning, about the role of these community groups and how important they are to provide that social support. Because all I see is, well, you're asking women to do more unpaid work, right, on top of everything else they're doing. And I don't know how we reconcile that, right? Because at one side, I understand the importance of communities and the role they play, and you know, in trust and in building in relationships, but also you're thinking about who's doing that in the community. But it's not just gender, you know, we've seen it in Laura's work around race, around ethnicity, around location. There are all these different parts which get left out when you apply a very securitized response to any outbreak. And again, very much saw it in Ebola, in Zika. It's not new to COVID, which is one of the things I find again most difficult about the COVID response is that we knew all this, right? Like we knew this and nobody did anything differently, right? And it's because, I argue, of this sustained securitized pathway that like it's securitized, therefore we do A, B, C, D, and the kind of lack of reflection of that. But I think things are changing. And I think this is changing in two ways. I think it's changing nationally. I think we're not seeing the, well, again, that varies by context. But internationally as well, I mean, the language of security, I have noticed, has completely dropped in global policy making circles during COVID, right? We now don't talk about global health security. We talk about pandemic preparedness and readiness, right? Yes, it's rooted in a security logic, but I think the recognition that the security part is wrong is starting to shift. So, for example, you know, my work is all kind of global policy level, and I'm heavily involved with. I sit on the IHR review committee for revisions to the international health regulations, the main piece of international legislation that we currently have for health security, and I'm heavily involved with the pandemic accord processes which are going on with WHO, which actually mirrors very similar to what Laura was talking about this morning as an international declaration on pandemic rights. We don't see the language of security at all in those places. And actually what those, particularly the pandemic accord processes that are going on is trying to be a much more inclusive, you know, system-wide, taking everything you guys are saying and people have been saying for many years into the way they're developing this pandemic accord. And the idea, for those of you who aren't aware, the pandemic accord, it used to be called the pandemic treaty, is supposed to be this global political declaration that's going to be a legally binding declaration under the auspices of the WHO to complement the technical language of the international health regulations and get governments to do better in future and build systems now. And it has all the, you know, the draft of it is you know, available online. You can all have a look at it. But it very much uses these concepts that we've all been talking about. It's about building systems. It's about universal health coverage. It's about thinking through the everyday structural violence that means people can't afford healthcare. And it's really trying to take it away from that kind of epidemic only, pandemic only approach. We see a lot of calls for equity and vaccine equity, both within the IHR revisions and within the pandemic accord. And there's this new multi-level, multi-sector platform that's taking place in WHO for that medical access to medical countermeasures. Again, it's not talking about security, it's talking about equity. Now, obviously, these processes are ongoing. We will see how they get negotiated. You know, my sense is that it's going to be a bit of a bust, and the pandemic treaty is never going to really have much meat to it, and all these pushes for equity and for health system strengthening might not happen. But I think it's demonstrating that there is this shift occurring away from this securitized response, because securitized response has basically failed most of the world's populations. The problem is that the very people who security response has supported are high income states, right? High income states who are the ones who are now pushing all these processes. So what we have is this real tension between the world knows and the public health community knows that securitization of health isn't working, and they know exactly how to do it. However, the people in the room doing the negotiation are quite happy with it, right? We're quite happy with not having equity, because actually for the UK it works quite well. If I was a UK negotiator, well, that's fine, right? Like I got my country populated, my country vaccinated. I don't want to have to make commitments in the future to doing it. So I think we're going to see this really interesting time in the next couple of years as these processes get negotiated, because you've got the public health community and some governments, you know, pushing away from this securitized language, and then you see the sort of the impact of countries for whom it has served this far. And that then leads to something new that's occurring, and this is where I'm going to end, because I'm very aware probably over time. But coming back to Periscope, right, and the work of Periscope, which is we're seeing this tension within global multilateralism, because you've got states that want equity, you know, low income states who were unable to access vaccine products and over countermeasures, trying to push. You're having these multiple kind of forums occurring and kind of different forum shopping or counter-institutionalization, depending on how you look at it, with lots of different processes happening with different governments wanting different things. And what we're seeing, I would argue, is then this retrenchment, or not retrenchment, but a move away from the multilateral to the region, right? And I think, you know, what we're talking about here this morning, here in Europe and Africa CDC in Africa, you know, we're seeing governments basically saying the global multilateral system and pandemic governance isn't working for us, right? If it's going to be rooted in the securitized logic, if it's not going to have all the mechanisms that we need to support equity, then we'll just go back to going down the regional process. And it's not just around kind of collective organization, but we're seeing, you know, for example, the EU had, you know, collective vaccine buying things. We're seeing things like Africa CDC and HERA now have their own mechanism for declaring regional health emergencies. And I think, well, actually, this is going to be the legacy of the failures of securitization at the global level and global health security, which is that we're going to see a much more fragmented governance mechanism. And I think that's going to lead to, you know, maybe some governance locations in some regions being more progressive in the way they build their regional competencies, their health systems, their the structure spaces, you know, that's going to look different in different places. And I think that means that next time we have an outbreak, we're going to see very different responses. And I will stop there.
Comfy chair. Before we, I mean, I'm going to ask all the panelists to talk to each other, but has anybody got a question that you want to ask or a comment about anything? I'm just concerned you've all been listening and not doing anything other than listening. Nobody's got a comment. Ah, you have a comment.
Yes, thanks. Good morning. My name is Lalji. I'm from Belgium. I'm so to say from the other side, from the biomedical side. So it's very interesting for me to be here. I was very intensely involved in the advisory bodies, and so I'm of course listening and absorbing all what's being said here, and trying to reflect at the same time. Well, I think there's a lot of feedback to give, but one of my questions is there's big dilemmas to keep everything that needs to be taken into account in the same time, nevertheless doing the right thing on the right moments to stop an epidemic, because yes, I have been, or we have been giving out also advice on we have to do this and we have to stop, etc. And knowing very well that these strong lockdowns or interventions would have severe societal side effects, and we were even not able to foresee what kind of side effects there would be. But at the same time, an epidemic of that nature has such a speed and such an impact that you have to stop it also. So there is the big dilemma. And now we are in peacetime in between epidemics. So now is the moment not only to do this kind of reflections, but also to translate this kind of reflections in real preparedness. And I'm very much in favor of what you said, that the preparedness from the bottom up and the ground level, etc. So also for us, we're thinking very much, but trying to bounce back to you, how to marry the combine the speed that you need to take action for epidemics when they are really big cards, and nevertheless not losing your democratic context, etc. It's a very big dilemma. Because, sorry, just one sentence, because we were confronted also the other way around on the slopes of severe waves, people in Belgium saying, oh, it's not that bad, and let's go, and we won't take any interventions, and people are fed up with it, and etc. So, I mean, very rationalist speeches as well, which slow down response, and then the response is also less effective. So very difficult to balance all this in the heat of the moment.
Maybe I'll just pick up on that in a way. Do you think one of the lessons of COVID is that democracies are not good with epidemics? And if we're going to have more epidemics, we need more authoritarian government. I mean, I'm just sort of, in a sense, it's an implication of what you're saying. If you've got to stop something, you've got to intervene, and democratic processes get in the way. And it kind of, it relates a bit to your points about securitization. You know, I think there's alternative trajectories going on as well. I mean, while WHO is moving away, UNDP is foregrounding security. It's now produced 4 international reports of trying to reclaim human security. And you know, as you pointed out, many of us have pointed out, that term security, while back in 1994, UNDP was saying, well, human security is taking arms out of security. Actually, if you use that term, it puts arms into security in all sorts of new places. And that lends itself to other forms of governance other than democratic forms. I mean, it's very striking to me what happened in Sierra Leone compared with Uganda, where the armies got involved in both places. In Uganda, where increasingly Uganda is being influenced by the Chinese models of governance. It wasn't a problem for the army to ensure that President Museveni remained in power. Whereas in Sierra Leone, where there's been a very close relationship between the army and the British Army, particularly because of the intervention of the British forces, the army obviously were very involved in Ebola, very involved with COVID at the beginning, then withdrew, and then guaranteed a democratic transition to an opposition party. And I think those sorts of dynamics are really important. And maybe thinking about securitization the way you're talking about it, possibly that's a red herring, but it's actually that militarized twist and that kind of enforcement associated with security is taking on new dynamics that we haven't really thought through, and COVID has highlighted. Those are my thoughts. Do you want to respond to that?
Yeah, talking about the kind of new forms of security we see. I mean, and you know, you talk about the military and the involvement and all these different ways. I mean, the thing that I was thinking about just now when you were saying that was what's going on in Brazil at the time. I don't know, you know, how many of you know what happened in Brazil was, yeah, well, obviously the government did nothing, right? Bolsonaro's government did nothing, and in the absence of that, what we saw was actually gangs take over the security, right? And obviously that happens in a lot of places anyway, but there's really strong kind of territorial governance occurring in favelas in Rio, right? Where the kind of gangs who traditionally would be in control of, you know, the location in terms of, you know, drug smuggling, whatever they're doing, were implementing COVID control. They were saying who could come in and out of their location, right? They were trying to implement MPIs because they saw the absence of that coming from the government, right? And the lack of trust in the government. And I think exactly this, right? You see these new forms of securitization of health appearing with new actors, right? And whether those new actors are a gang in Rio de Janeiro or the EU as a new health security actor, as Periscope is talking about, right? You see these new forms of security because what was currently there wasn't working.
And also security very clearly connected with enforcement.
Yeah.
That it's not security in the sense of, you know, making people feel better about their lives. It's changing behavior with punitive measures. So, yeah. Melissa, you worked in Sierra Leone. Why did the army withdraw in Sierra Leone?
Well, I think you're absolutely right that there's a very different context, and the relationship between the military and the population is different, and it partly reflects that different history of a certain popularity and trust in the military, who, supported by the British, did help end the rebel war as it was understood at that time, and many felt that. And I think we've now got a different context in which the army is seen more as a kind of set of professionals who are able to do kind of logistical things and don't act with such violence, and are not quite so politicized and party politicized as they are in Uganda. So these contexts really matter. But they weren't absent in COVID. I mean, the village where I've lived for a long time is right on the border of Liberia, and And people there were saying, yeah, they put all these border guards on, the army were patrolling the Liberian border. And the guards would come into villages, they'd find cigarettes and food money and have sex with our daughters. And it kind of, in a sense, added to the hassle, it added to these intersecting characters. So I think contexts are different, but I think the question maybe is, when there's securitization happening at all, is there always a military twist, as you put it? And does that always imply a kind of enforcement that is problematic to people? I wanted to come back to Claire, but that was really interesting, but maybe a little bit to challenge your claims about the environments you're moving in, where a securitized discourse seems to be diminishing, because I think in other contexts we're still seeing it. Some of the interviews we did for this project, we had people like Mike Ryan in the health emergency still talking about global health security, albeit saying it needs to be built from below. But what does that really mean? We've had this new Lancet series on One Health, which is all about One Health for global health security. And maybe it's a reframed version of global health security, which involves collaboration and a lot of blah blah, but in the end it's still global health security. And I think UNDP, I've just come back from New York actually, where UNDP absolutely are talking about global health security and indeed global security around all sorts of other things, including climate change and environment. They reframe it as human security, but there's still something about it being securitized, which is, I think, problematic, where it takes one down a certain route and away from others. So I'd be interested in how we might kind of nuance this discussion.
Do you think that when security is used in that language, back in 1994, the idea was, as I've already said, to take weapons out of security. But do you think that that's now gone? And now when people talk about security, they're actually talking about restricting choices, the systems of governance that prevent people from doing certain things with enforcement measures. It doesn't at one point about One Health, just before we think about it. I mean, within Periscope, several colleagues have been working on One Health, and whenever we talk about One Health in Periscope, people talk about the need to think about nature, to think about the environment. It's quite a sort of soft idea in a way, and the critique of it, perhaps, within the discussions we've been having within Periscope, thinking about the European context, it doesn't have much edge to it. It's very different in an African context. I mean, we were in Uganda recently on the border areas with Congo, and we had a meeting in the border locations, and the government officials there were saying, oh yeah, we have taken on board One Health. They were very enthusiastic about it, and they were giving us this lecture. Do you remember about we have One Health because people are living with their animals, because they're smuggling things across the border from the national park. Also, they were completely committed to One Health. They were also saying, yes, it was very good the soldiers were here because our people are very stubborn and sometimes they need persuading. And so, at the end of the meeting, I said to them, well, so is your recommendation that we need to have militarized One Health? And they all said, yes, that is the way forward. So I just wonder whether this shift in security is actually towards, what we've learned from Ebola in Africa and we've learned from COVID is that governments really like enforcement measures. I know, it's a thought. We're in South Africa, going to the central part of Johannesburg, which is all controlled by militia groups.
I think there's really well taken. It's not only government, it's other forms of vigilante groups, the terrorist mafia types of organizations. And I think what is the obvious point as well is that there are these commercial interests that come in, and so that people stand to gain from the securitization, but informal forms of authority, but also formally. And I think that's what makes me less optimistic than Claire about this reframing really happening at global level. I think there's a lot of talk about equity and trust and so forth. But again, going back to that point, I think that I think partly it's the disciplines represented. I think it's really difficult to really grapple with these political interests and the rest of interests. And I think just to go to your question, I do think there's also a particular, you were saying, you know, in the moment one has to act. And I think that's my other concern, is that actually I'm caring more about preparedness as readiness rather than this longer term emphasis. And I think that's partly because there needs to be a reforming of funding mechanisms, because in our regional interviews, people spoke about, which is quite interesting in contrast to the UK, where there's this focus on the sort of hollowing out of the healthcare system by COVID, and actually people were saying, oh, you know, we managed to get more ICU beds because of the investment that came in COVID. So there are these episodic investments and not a longer term strategy. So if we're really going to shift to the small systems notion of preparedness, I think there needs to be a big rethinking about how money flows in. And I mean, for example, with MPOX recently, you know, a public health emergency of international concern, resources flow in. WHO stops the public health emergency of international concern, says we're going to shift to a longer term strategy. And how is that not just code for saying, well, in endemic places, this will, you know, historically endemic places, MPOX will continue, but we're seeing a decline of cases in the multi-country outbreak, therefore it's no longer a priority. So there's also this politics of priorities that play out. And what would a longer term strategy look like? Are there funding mechanisms, financing mechanisms for that? So there's a real sort of structural question.
Okay, we haven't got very long, but I want to throw a last question to all four. I'm going to ask Melissa. If not said anything, I'm going to ask you to respond to this. I was listening
Can I
to.
say one thing?
Wait. Oh, okay, go on. Is it short?
Maybe perhaps we need to kind of nuance this discussion around military, because there's a pretty sort of big split, you know, yes, we need soldiers in military help. No, we don't need soldiers in delivering healthcare and during outbreaks and stuff. And not a lot of other way, a lot of pressure. Follow the money, find out all these institutional interests which are invested in certain kind of responsibility. But if you actually look at the specificity of the situation, critical that I've been about the Ugandan engagement with COVID, those many significant number of Ugandan army officers were deployed to Sierra Leone during the Ebola outbreak and were hugely influential in training people to enable Sierra Leoneans so that they develop the confidence to rehydrate people, and that was very, very influential in leading to sort of upturn in survival rates. So there is also expertise embedded in the military to deal with outbreaks that we kind of don't want to do. So how does that feed in as well?
Well, I mean, given that you were advising the Ugandan government and you had meetings with these military officers, it kind of it's linked, and it's linked to the question I wanted to ask all four of you. You know, all four of you have been advising international organizations and government. Maybe advising is the wrong word. Been at meetings where apparently advice is being sought. Laura, in the earlier session, was talking about her work. I mean, like Melissa, she was on SAGE, giving advice to the British government. And she made the point that actually the British government ignored the science. You know, and it's become more and more apparent that the British government had all this discussion with scientists, but actually they completely ignored it. And kind of the three ministers were making a decision, to some degree, actually being advised by people from the Ministry of Defence, but they seem to have ignored that too sometimes as well. But basically, what was going on in the UK, just as an illustration, that the academic community was being mobilized, science was being mobilized, many colleagues at the LSE were mobilized, but they were mobilized for what? They were mobilized to give legitimacy to government officials. You've been advising. I mean, you were on a task force which predicted COVID before it happened, and none of the recommendations were implemented. So my question is, as as analysts, as scholars, do we compromise and engage with policymakers only to find ourselves compromised? Are we just, this whole process that we're discussing about here, is it about just buying into political establishments and giving them legitimacy? At what point do we have to stand back and say, you know, that the emperor has no clothes? And at what point do we stand our ground as scholars and observers? Melissa, you can answer. That was the question I'm going to ask you.
It's a huge question and you're not going to get a particular response, but just like obviously you touch your finger on a really, really important set of issues, and it is deeply troubling the way in which academics are used to legitimize policies which are bankrupt.
And violent sometimes.
So that is obviously a huge problem. Having said that, probably the biggest impact I have ever had has never been acknowledged, which is fine, but nor should it in a way, which involved going to the Ministry of Defence during the outbreak in the UK, and thinking about what kind of response they're going to have. They have these vast numbers of health people, personnel, who are going to be deployed on the HMS Margaret. And we're planning a highly militarized response, not just building those treatment centers, but they were going to be at the roadblocks, they were going to be enforcing quarantine, all sorts of horrendous things. And it was as a consequence of an intervention by myself and a couple of other colleagues, whatever, in which we just been crazy. We put a very for that, and it didn't. And they just did themselves. So it can be helpful.
Melissa, you're director of the Institute for Development Studies. What's been your most important intervention?
I mean, you're touching on a vast set of issues about the politics of science advice. I mean, there are people who write about this, different national political cultures, the fact that information is always politicized and the ways it's dealt with is not just about projected evidence, it's about evidence in context. The tactics for influence often require not what goes on in formal meetings, which goes on in behind the scenes. Melissa's story, which was part of the work we did on the Ebola response anthropology platform, which had a formal part of the Ebola SAGE. It was the Social Science Committee, but actually it was much more the conversations that happened in this case with an anthropologist who was part of the Ministry of Defence, who managed to shift things through tactics from the inside. I think just really tune us into the need to understand and look much harder at the politics of science policy processes, and to recognize these as multiple and taking place in multiple sites, not just in formal committees, but through relationships and through tactics and through looking for an opening and trying to find a way into it, and then trying to sort of shift things from the inside. And I think all of the wider work that's done in development, including by my colleagues at IBS, is about all of that. The pathways from research to impact are twisting, they're relational, they depend on networks, they depend on often quite personal forms of advocacy. And to assume that science policy committees that are thought that are set up for pandemics, either in national context or globally, are the main way forward to shift things, is I think probably mistaken.
Unless you've got something burning to say.
No, absolutely, I agree. I think it's my work at the WHO level, 100% agree. Those the panels, the formal panels is good representing. It's all in the corridors, the copies. That's where you see the changes occur.
And it is a reframing of some of the sort of core assumptions as much as it is about technical advice. And I think that's often harder to achieve.
And it's just to add, it's also problematic, right, in terms of transparency in governments, that actually that's where decisions are happening. That is going to exclude people who aren't in the room, right?
Exactly.
And it's not transparent, and I think, but that's still how it happens, right?
Yeah.
And it used to be called a boys network, and it's maybe less boys and maybe more women there now, which is a good thing, but it's still it's that process, and I don't know how we make that more accountable.
I now think we're going to have coffee now so that we can go network and have all these. Thank everybody for attending. And yeah, what they do now, it's a program now. It's another session.
Yeah, there's another session here now.
But I'll wait out a cup of coffee.
Yeah, we have macro data and evidence stream.
Oh, now macro, stay here, you get macro data and evidence. Thanks everybody for coming.
Thanks.
Okay.